for this study. Dr. Kesler is an assistant professor of psychiatry and behavioral science, a member of the Cancer Center and BioX program at Stanford University, and a licensed clinical neuropsychologist. Her research is focused on the effects of cancer on the brain, as well as the development of practical methods for cognitive assessment and rehab. Dr. Kesler is also an attending neuropsychologist in the Child and Adolescent Psychiatry and Behavioral Medicine outpatient clinics at Stanford University. Whoa, that's a lot. She does a lot of great stuff. We're also excited today to have Dr. Love on the phone. She will be moderating this session and will be answering some questions along with Dr. Kesler. And all of you also have the ability to type in your questions, and we'll be able to monitor those questions and send it over to Dr. Kesler. So thank you again to Dr. Kesler for joining us, and let's get started.
Well, thank you for having me. I'm really excited to be here to talk about this topic that I believe is really important. So just to start out, I don't have any disclosures or conflicts of interest related to this presentation. And as an overview to the study, so the participants we had, we were looking for were women who had primary breast cancer, so stages 1 to 3B, I believe. So basically, we just we took people who did not have any distant metastases, and our age range was 40 to 75 years, and we were looking for 3 groups: women who had undergone adjuvant chemotherapy, those who did not receive any chemotherapy, so they could have had hormonal therapy or radiation, but just no chemotherapy. And then we also had a group of women who had no history of cancer. And so those were our 3 groups. And then we had 2 main questions that we wanted to ask. One was, what are the biological or brain markers of this concept of chemobrain? We knew that it existed from our clinic and from patients telling us that things were different for them in terms of their memory and their thinking skills. But a lot of people weren't sure if this really existed, and it was kind of a controversial topic several years ago. And so, we wanted to look in the brain and see, can we determine if there are some type of biological indicators of this problem that would help us better understand it. And so the way we did this was that we gave the participants some paper and pencil tests of memory, thinking, and attention. And then we also did a brain MRI scan, so that the MRI, for those of you who are not familiar with it, just uses a really powerful magnet to take images of the brain. And so they did those 2 things. And then we also had a subgroup who we enrolled in a cognitive training program. This is also known as mental exercises or brain exercises. And this was on the web. And the participants logged into their personal account that we created for them, and they did a program of exercises that were designed to improve the kinds of issues that patients report associated with chemobrain. And I'll talk more in detail about that in a bit. So that was our study, and so we, we asked for the Army of Women's help in getting us some participants, and we were really, really excited and almost overwhelmed with the number of people who were willing to help us. We had over 1,200 women who responded across all 3 of those groups too, and we actually met our targeted enrollment within 2 weeks, which for most studies usually takes 5 years. So this was we couldn't have done this study at all without the Army of Women and the people who were willing to volunteer and give up their time for this. So just a little bit of background on what are the type of cognitive difficulties that we see with chemobrain. And the research suggests that around 60% of women are affected in some way by these cognitive issues. And of these, around 30 to 40% unfortunately show no or very limited recovery over time. So the reverse of that is about 60 to 70% actually do show some recovery. So that's that part is very good. But we're kind of focused on, why does this subgroup of women not show very good recovery? And the most common difficulties that we see are executive functions. And so those are things like planning, organization, multitasking, sometimes inhibiting responses, or what we call cognitive control. Those are executive functions. Any kind of skill that you need, to do a really complex task, or what we call high-level tasks. Those are usually executive functions. And then memory, of course, remembering things, and this includes remembering things from the past, like people's names, or what you did. But a lot of it is remembering to do things. So in the future, you're supposed to go to the store and remember the things you need to get there, or you're supposed to remember to at some future time or some future event to do or say something. Those become very difficult skills. And then processing speed is another one, and this is kind of what it sounds like. How quickly do you think? How quickly can you come up with the word that you want to say, or come up with a solution to a problem? And a lot of patients report feeling slow or sluggish in their mental skills, and that things just take them a lot longer than they used to. And then the fourth most common one is attention. So patients sometimes report that they just can't focus as well anymore, that they get distracted more easily, that noises or things in their environment are distracting to them, and they can't concentrate unless things are just completely quiet and they have a really controlled environment. So those are the four most common difficulties that we see. And we really aren't exactly sure what causes chemobrain, and we call it chemobrain, and that is a little bit inaccurate because we know that there are some other factors that might also contribute to these issues. Certainly chemotherapy does, but some women who have only undergone radiation or only undergone hormonal blockade also show some changes, and so these might contribute in some way. There may be certain skills that are more affected by chemotherapy versus radiation versus hormonal therapy, and we just haven't done enough studies to figure out exactly what those differences are. But there are several things that contribute, and also some women who have not even begun any treatments but are newly diagnosed also show some slight changes, and so it could be that the cancer itself is causing some differences, and so the cancer tumor or the cancer pathogenesis is another possible factor that contributes to these cognitive difficulties. And then, of course, we also have what we call host factors, which are things like how old are you, how mentally and physically active have you been throughout your life, are there genetic types of variations that make people more or less vulnerable to having chemobrain. And so it really is all of these factors that you see here that may play different roles in this cognitive effects.
Shelli, what about also the psychological aspects of being diagnosed with cancer? Maybe depression or just whatever, shock, or that could also probably affect your mental functioning.
Yeah, definitely. Those are, you have, when you are diagnosed with a disease like this, you certainly have some psychological reactions, and some people have those to a greater extent than others, and they are definitely associated with cognitive issues. And the thing about that is that sometimes the cancer itself and sometimes radiation and definitely chemotherapy can alter the body's ability to deal with stress. And so you have, the understandable normal reaction to having, this life-threatening illness and having to go through all of these difficult treatments. But then on top of that, you also have some of these treatments and the disease itself altering the physiological aspects of your body that actually control depression. And so it's difficult to tease those out. But yes, that's a really good question there that we're not sure where to put that in terms of whether it goes in host factors or whether it goes under one of the treatments, but that is definitely a contributor. So for this study, the main theory that we were looking at was a concept of brain aging. Chemotherapy and cancer, some people believe that it kind of makes you age faster. And we wondered if this was perhaps the mechanism that this disease and its treatments cause the brain to also age more quickly, and that is why we show increased cognitive issues. So here you just have a little schematic of what I mean. So as we age, we actually undergo normal brain changes that lead to some mild cognitive decline. But if you have an injury when you're aging, such as cancer or cancer treatment, or it could be any other thing, injury is very widely defined in this model. It could actually be depression is the injury. It could be an actual brain injury where you get into a car accident. It could even be a really big stressor like losing your job or going through a divorce or losing a family member. That could also be considered an injury. But in this study, we looked at injury as being chemotherapy, basically. And so, our theory was that this injury then caused some acceleration or speeding up of the normal brain changes that occur when you age, and that this resulted in increased cognitive decline, compared to other women of the same age. And so this is just kind of showing you, what we were thinking as we went forward with the study. And so there are some regions of the brain that are a lot more vulnerable to the aging process. And I just wanted to go over these briefly because I'll use these terms and I'll continue to explain them as we go along, so you certainly know how to learn these or remember them. The hippocampus is an area that's really deep in the brain, and it's extremely important for memory and learning. If anything happens to the hippocampus, memory and learning kind of just go away. They don't work as well at all. The prefrontal cortex is an area in the front of the brain that is really important for pretty much everything that your brain does, particularly those executive functions that I talked about, those planning, organizational, problem-solving types of skills. But it also plays a role in language, memory, motor function, and definitely the emotional processing. So, people who have prefrontal cortex abnormalities often experience an increased vulnerability to depression and anxiety. We also see changes in brain connectivity. So you have these different regions like the hippocampus and the prefrontal cortex that have these kind of specialized skills, but in order for them to work, those regions all need to be connected together, like on a cell phone network. They all have to be able to communicate with each other really efficiently, or none of those functions work very well. And one of those networks that connects all of these different regions is called the default mode network. And it has a lot of different structures in it that I won't go over, but it's really important for monitoring what's happening, so attention, memory, self-reflection. So when you're just kind of sitting there, not really thinking about anything in particular, this network keeps all of your different brain functions kind of online and ready to go when you need to do something. And how these networks are all connected together is with something called white matter. And these are just your brain pathways and your connections that keep all of those different regions in communication with each other. So in our study, in this Army of Women study, we did look at hippocampal volume. And this was a study that we published very recently. And you'll see in the blue are the women who had undergone chemotherapy, and in the red are the women who were just healthy women who didn't have cancer. And you can see that the blue box is quite a bit lower than the red box. And what this means is that the hippocampal volume in the women who had undergone chemotherapy was much smaller than their age-matched healthy controls. And so this is, one biological or brain marker of memory problems, because the hippocampus, as I was saying in the previous slide, is extremely important for memory. And so if you have, this accelerated loss of hippocampal volume, then you might have more difficulties with memory. And then prefrontal. So prefrontal, again, is that region important for executive function, like multitasking and problem solving, and also emotional regulation. So we published 2 studies, 2 papers from this Army of Women study in 2009 and then one last year, looking at prefrontal function. So we gave the participants an executive function task. In the top one, the top picture was a memory task actually, but they had to do some executive type things to try and remember, use some organizational skills to try and remember the information. And the areas that are yellow and orange are the areas where the women who had undergone chemotherapy showed less activity in the brain compared to the healthy controls. And you can see it's all kind of in that frontal area where those executive functions are. And what we concluded from that is that these organizational skills have become compromised, and so it's more difficult to remember things if you can't organize that information very efficiently. And then in the lower box with all the different colors, that was a follow-up study to that 2009, where we then wanted to also compare the women who had not had chemotherapy. And you can see that there's this really nice staggered response here. I don't know if you can see my arrow, but the green are the healthy. You can see the arrow?
Mm-hmm.
Okay, so the green are the healthy women, the red are the non-chemotherapy treated, and the blue are the chemotherapy. So you can see that they kind of, the ones who did not receive chemotherapy also are slightly lower than the controls. So there is an effect here of just the cancer itself and or the radiation, because some of these women had experienced radiation. So there is this change in prefrontal function associated with executive problem solving and multitasking. So again, more evidence that there are some changes in the brain following cancer and chemotherapy. And so default mode network, this again is that network that gets your brain ready to go. So it's what we call a resting network. It's more active when you're at rest, when you're not actually doing anything. And it's really important that it be active at that time, because your brain is, you can think of it like a laptop. When you put your laptop on sleep mode, it's not all the way off, it's ready to go, but it's not really doing anything. And that's what this default mode network is. It's kind of like your sleep mode on your computer. It's not really doing anything specific, but it keeps your brain ready to go. So you can imagine if this network isn't working very well, then your brain is not quite ready for things, and so it might take it a little bit longer to get ready, or to actually focus, or to call up the memories that you need in order to do the task that you want. And so there were 2 studies that we published on this network, and we showed that there were some big differences. This main one here is there's this area in the brain that you can see here with this arrow, this little green ball that is kind of a hub, like a cell phone tower for this default mode network. And if that one is knocked out or not working, then the whole network goes down. And over here in the chemotherapy treated women, you can see that that hub is missing. It doesn't mean that that region is missing, it just means that it's not working in the network like it should. And then we also see this same region, when we look at function, is activating improperly during certain tasks. So this is kind of complex, but basically what it means is that we've found some evidence that this default mode or this readiness network is not functioning properly following chemotherapy. And so it helps to explain why processing speed and attention and even memory are not working quite as well as they were before. And then white matter, these are the pathways. You can kind of see this very nicely, how these various pathways connect different regions of the brain and help them communicate. And what we find is when we compare women who've had breast cancer to healthy women, that there are certain regions, and they're shown here in orange, that where these pathways have thinned out and are not communicating, are not transmitting information very efficiently. So this is another explanation for why some of these cognitive issues have slowed down and have become less efficient and less effective following breast cancer and chemotherapy. So I thought
so it's all in our head, sort of.
Yeah, a lot of my patients have said that their oncologist told them it was all in their head, meaning that they were imagining it. And it actually is all in your head. Your brain has undergone some changes, and a lot of those changes do improve over time. But there are biological factors that contribute to this notion of chemobrain. And we've shown very clearly that it is not just imagined, that it's not just stress either. That's been another explanation for that. And well, like I was saying, stress does definitely contribute. We have all of these results that I've just showed you are controlled for stress and depression. So we either excluded women who had significant stress or depression, or we statistically controlled for that because we wanted to see, what are the actual brain issues that are causing this chemobrain problem that don't have anything to do with stress and depression, but are actually due to accelerated aging or some type of brain injury. And so it is some bittersweet news. There are some brain changes that occur on average in women who have had breast cancer and chemotherapy. But the good news is that we are learning what those changes are, and we can figure out how to address them. Whereas before we weren't sure that it really existed, or I was pretty certain, but a lot of people weren't sure that it was a real thing or that it even had a biological basis for it. And so the way that we address cognitive difficulties, there are, unfortunately and fortunately for us, the brain is extremely complex. And whereas for a lot of other biological or physiological or medical issues, we have specific treatments for them. And in terms of when the brain has a problem, we often don't have specific treatments, and so we have to do kind of this milieu or this combination of different therapies. But what we know for certain is that one of the best ways to improve your cognitive function and actually even reverse brain changes is physical exercise, aerobic exercise. And the Mayo Clinic has published some guidelines on that, because there are, a lot of people say, well, how long should I exercise, how often? And it's sort of difficult to answer. But if you look at the Mayo Clinic's guidelines, they say at least 4 to 5 times a week for 20 to 30 minutes a session. And that doesn't mean being a triathlete or running marathons or doing anything super intense. It just means what they suggest is getting your heart rate and your respiratory rate elevated. So that could be just walking or doing yoga or something that you enjoy, but the important part is to do it regularly. That's when you see the improvement in cognitive function and the reversal of these brain changes, is when you do have a regular exercise program. So whether you do it 4 days a week, and whether you do that Monday, Wednesday, and whatever, that's not so much important as that you do it very consistently and that you find a schedule that works for you, that you can really do regularly and stick to. Mental exercise has also been shown to improve cognitive function and to reverse brain changes. And I'm going to talk a lot more in detail about what that means. And then also, as we were talking, these psychiatric symptoms, meaning depression and anxiety, really need to be addressed. And this also includes fatigue and sleep disruption. So if you're having fatigue and insomnia, all of those things are going to make cognitive problems worse. And so you really need to, if you're having depression, if you're having anxiety, if you're having these kinds of symptoms, you need to talk to your physician think about some psychotherapy to help with the depression and anxiety. Think about perhaps some medications that might help with those. But you definitely need to go in and get those addressed, or anything else that you do to help with your cognitive problems is going to take extra, just more time and going to be more difficult. Sometimes patients can get cognitive rehabilitation, and this is a really good way because it's really the standard of care and treatment for cognitive difficulties. The problem is that it's not widely available and insurance doesn't often cover it. But cognitive rehabilitation, you can ask your primary care physician or your neurologist or an oncologist maybe for a referral to cognitive rehabilitation. Now the people who do cognitive rehabilitation are neuropsychologists, speech pathologists, and occupational therapists. You just have to make sure that they have that training in cognitive rehabilitation because, like I said, there are not a lot of people who do it. But what it means is that you go in and you meet with the clinician, often weekly, sometimes more, and they will often do an assessment of your cognitive skills and then formulate a treatment plan where they help you to learn new strategies for dealing with cognitive issues. Those can be, using assistive technologies such as a smartphone for helping with memory, learning new ways to multitask and do executive functions, and also dealing with certain, to some extent, some of the psychiatric issues that surround cognitive difficulties as well. One thing that I recommend is to consider a neuropsychological evaluation to track your cognitive status, to know what exactly your profile of strengths and weaknesses are. You need to do that if you're going to go into cognitive rehab anyway. And it's a good way of keeping surveillance and tracking what your brain is doing. Even if you're not having any specific problems at the time, it's really, really helpful when you have certain risk factors like breast cancer and chemotherapy to have this evaluation so that, in a few years, if you do start to experience some difficulties, then your clinician has that previous evaluation, and it just makes it a lot easier to know exactly what's going on. And then there are some medications that some patients find helpful for cognitive difficulties, and those are typically prescribed by a neurologist or a psychiatrist. And so you can get an evaluation from one of those types of physicians to see if there is a medication that might work for your particular cognitive issues. So in terms of this mental exercise, so a lot of my patients were like, I don't want to do any more medication. I've already gone through all this chemo and radiation. What is there that I can do that doesn't involve medication? And so that will be these mental exercises. And so my group developed a curriculum of mental exercises in collaboration with a company here in San Francisco called Lumosity. And we had 50 breast cancer survivors who were randomly assigned to either the active treatment, so they got the mental exercise program right away, or they were assigned to a wait list where they waited 12 weeks and then they got the mental exercise program. And this is available to the public on lumosity.com. It is the courses, there are two courses that we created, Cancer Recovery 1 and Cancer Recovery 2. Cancer Recovery 1 focuses more on executive functions, and then 2 focuses a little bit more on memory. And the participants did this 15 to 20 minutes a day, 4 times a week for 12 weeks. And so it is kind of a commitment, but this is how mental exercise works. It works the same way that physical exercise works. You have to do it regularly, and you have to kind of get your brain activation elevated. And so the exercises start out kind of easy, but then as you get better at them, they get much harder. And just like if you were doing a physical exercise program, if you just stay at your same level the whole time, it doesn't help you as much as if you continue to increase the intensity of that exercise. And so they did this. This is what the interface looks like. You have, for each session, you have an assignment of exercises that you're supposed to do. It starts out with, telling you what the exercise is like, and then when you click this next button, it gives you the opportunity to to choose, show me how to play, or to just go ahead and do the exercise. And you have you can look here at, how you're doing, and go to some different assessments as well. So here's what one of the exercises looks at. If you click the How to Play button, it gives you the instructions, and it's actually animated, so it shows you, what you're supposed to choose based on what you see on the screen, and then it has some written instructions as well. And then you go forward when you're ready and you do the exercise. And it tells you, how well you're doing, how fast you're responding, what your personal best is, so that you can try to beat that each time. So when we analyzed this data, so again we had the waitlist group who didn't do it for the first 12 weeks, and we compared those to the active group who were doing it. And this is an executive function task called the categories test. And here's the change, so the post-assessment versus the baseline assessment. And you can see that this active group is much higher in terms of their executive function. They experienced an increase in their executive function over the waitlist group, and this was a significant effect. We also looked at memory, and again here's the active group in red, and they're showing a significant increase in their memory skills. The waitlist group actually went down a little bit in their memory skills, and we weren't sure exactly why that was, but this made it a really big effect for those who are doing in the active treatment. And then this finding was actually surprising. We measured depression, just like I said, as a way to control for depression. We didn't actually think about the exercises improving depression at all, but then we noticed this really remarkable change in the active group. Their depression scores went down very significantly compared to the waitlist group. So having these mental exercises, having something that you can be doing to help with the cognitive issues seems to decrease this psychiatric distress. So in summary, we do see cognitive changes following breast cancer and its treatments, and these changes do have neurobiologic causes or brain causes. There are some changes in the brain that seem to be associated with these cognitive changes, or with what we call chemobrain. And women who have not undergone chemotherapy do show some mild changes, but women who are treated with chemotherapy appear to be at the highest risk for these changes. And it's important to understand this term risk, because when you see studies like this, it only means average. The average person in this group has those problems. And there's always going to be a distribution. So in our studies, we had women who didn't have any problems, who had chemotherapy, who were older, who had all the risk factors and did not have any problems. They had recovered. And then we had some women, like I said, who didn't have any chemotherapy, who didn't have any radiation or hormonal therapy or any of the risk factors, but they did have cognitive issues. And so there is a lot of individual variation. So it doesn't mean that breast cancer and chemotherapy cause cognitive problems. It means that they're a risk factor for them. And we don't yet understand what all of the risk factors are. And so some women are going to have difficulties and some are not. But in terms of the ones who do, we believe very strongly from this evidence that it is because there have been changes in the brain. The really good news about this is that this study has shown that these cognitive issues can potentially be improved through a program of regular mental exercise. So, there are some types of neurological problems like Alzheimer's dementia and strokes in some cases where the cognitive dysfunction is pretty permanent. And so the very good news about this is, even though we are showing some brain changes associated with breast cancer and chemotherapy, that they are very amenable to intervention. So I'm sure a lot of you are really curious about what we mean by mental exercise. Certainly you can use the kind of these cognitive training programs that are available. There are lots of commercially available products, Lumosity being one of them. And like I said in the beginning, I don't have any conflicts of interest related to Lumosity. We actually had to pay them to create the curriculum and pay them for our participants to use it, so we do not receive any type of profit from people using Lumosity. I personally have looked at a lot of different cognitive training programs and can tell you that Lumosity is the best. It has the most diversity of cognitive training exercises, it's the least expensive, and it's the easiest to use because it's just on the web. You can just log onto the internet and use it. But there are some other good ones that you should look at to make sure that if you want to try these out, that you have the one that's going to work for you. Posit Science makes one. That's a software program that you install onto your computer. Brain Age is one that's really fun. It's more of what we call a platform training program because you need a special piece of equipment called a Nintendo a DS or a PlayStation. And then there's another one called CogMed. That's also a software program that you install. And all of these, with the exception of Brain Age, do have some research support suggesting that they work. I put Brain Age in there because a lot of my patients like it. I use it and it's really fun. It's a fun one. But you don't have to do those. Some people don't like computers, don't like doing computer-type games. So one of the easiest and most effective ways that you can get mental exercise is through something that I call active journaling. And so this is kind of like a diary where you're recording, what's happened to you, but more importantly, you record what your thoughts and your ideas are. And so it forces you to actually think about things. You can write something that has happened to you during the day, but that is not going to be very helpful if you just do that. What you need to do is, write the thing that happened to you and then talk about what your thoughts about it were. What ideas did it generate? What discussions did you have about it with your friends or family? Did you learn anything about it? So it does two things. Well, it does a lot of things, but it helps you with your language skills because you have to write this out, in a way that makes sense and isn't just, a bunch of notes, but you're actually writing out kind of a little mini essay and talking about all of these things. And then it also, you'll find if you try this, that you actually start thinking more during the day because you're going to have to record something that evening. And so you start remembering better because you're paying more attention to the things that happen to you throughout the day, trying to find something that's going to be good for you to discuss in your journal. And so I make my patients all do this, and they all show really strong improvements in their memory, in their language, in their organization, and in their thinking skills. Because this exercise forces them to practice those skills. Hobbies are really good mental exercise. Reading, studying, learning languages, gardening, musical instruments, crossword puzzles, travel, going to museums, anything that is stimulating to your mind is going to improve your cognitive function. Again, just like with anything, you have to do these kinds of things regularly. You can't just do them once a year or twice a year, but you have to be integrating these kinds of activities into your life on a very regular basis. And also, if you're reading, a lot of people choose that as their mental exercise. You should try to, you should certainly read the things that what I call are guilty pleasure reading, and you just read them because they're fun. But you should, integrate in a couple of books that are a little bit more challenging for you, that are kind of outside your comfort zone or are on topics that you're not really familiar with, because that's what's really going to push your brain to recover and to get stronger. Social interactions are a really great way to get mental exercise. This is just discussions with friends and family about current events or about thoughts or ideas or feelings that you have, and really engaging with them and thinking about what they're saying and kind of what you want to communicate. And it helps you to practice again, some of those organizational and word finding skills. And this part is frustrating for patients, at least the ones that I see, because a lot of them have word finding issues. But if you really keep practicing that, and you have a good support group who will be patient with some of that in the beginning, you do actually get better over time. Volunteering, being parts of groups, all of these things are very stimulating to your brain and will help it to become stronger. Again, so the most important thing is not so much what you choose as your regular mental exercise, but that you do it regularly and consistently. So get on a schedule, just like you do with physical exercise, and set a goal for how often per week you're going to engage in something stimulating to your brain. You should try to challenge yourself. Like I said, with the journaling, you're trying to challenge yourself to think of something and not just write down what you did. Or with if you choose the cognitive exercises, those will automatically challenge you by getting more difficult over time. And another thing that the brain really craves is novelty. So whenever you can kind of integrate something new, like I said, a new topic for you to read about, or a new stimulus that you haven't had before, that you haven't tried before, all of those things are going to be really, really good for your brain. So those are the three elements of successful mental exercise. And then just quickly, thanks to my lab and all of my collaborators who have helped with this research. And I think that's the end of my slides. Yep.
Thank you, Shelli. This was really great. It makes me want to run right over and start exercising my brain immediately.
Yep.
But just listening to you was exercise of the brain, I think. Do we have questions?
We do have questions. Can everybody hear me okay?
Yeah.
Great. Okay. So we have somebody commented that the trauma of being diagnosed is like with post-traumatic stress disorder causes these issues. Is there anything in relation to post-traumatic stress disorder?
Well, we do know that women who have been diagnosed with breast cancer are at a slightly higher risk for PTSD. And PTSD definitely increases or worsens cognitive problems, but there's not any evidence so far, but that could just be because there haven't been very many studies that PTSD causes cognitive problems. It's definitely probably a contributing factor if the patient has a diagnosis of PTSD. Like I said, it will worsen cognitive issues and make them last longer and make them more difficult to treat. But it's not a causative factor by itself.
Okay, great. We have another question. Bernadette wants to know, how does another disease affect chemobrain, for example, Parkinson's?
So if we go to that model here, so anytime that you have an injury, these things can be, additive. So if you have more than one injury, which Parkinson's could be considered an injury, then this just becomes more accelerated. So if you have, PTSD is another type of injury, so you have that on top of cancer treatment, then this just becomes more accelerated, and so you probably might see even more cognitive issues.
All right. We have, Brenda has some questions. She has been evaluated for cognitive decline after her IVC treatment, had her neuro workup. She's been working on doing the exercises to improve cognitive functioning, and her question is, how do I document and verify the problems I've been having from a clinical point of view, especially since neurological evaluation was not useful in that regard?
So I'm not sure if it means a neurological evaluation or a neuropsychological evaluation, because those two are very different. Neurological will look more at nerves and even MRI changes, but with this research it often doesn't show up on an individual level. We kind of have to average a lot of people together to find the effects. that I've shown you. If it's a neuropsychological evaluation, that would be the paper and pencil test of memory, and that one is a little bit better for detecting these. But unfortunately, that one also is sometimes not sensitive enough to these types of changes. You know, we often see patients who show normal scores, and yet they're having significant problems. And so you kind of have to have someone who understands this research and this phenomenon consulting with the physician, which is probably very difficult at this point since not very many of us are looking at this. But one thing you can do is do a consultation with someone about the evaluation. If it is a neuropsychological evaluation, I'm afraid I'm not entirely certain what you would do if it was a neurological evaluation. Probably the same.
It was a neuropsychological evaluation. She
Okay.
did not have any brain imaging.
Okay, so then that is probably what's happening, is that sometimes those tests are not sensitive, and if the practitioner was not aware of these issues and not abreast of this research, would not know how to interpret those properly. And so my advice would be to try and find a consultation with somebody who was more skilled and experienced in medical neuropsychology, and particularly had worked with cancer patients before.
Okay, wonderful. Thank you. So switching paths, we actually had Alice commented, wow, so all the patients that say, I feel like I have brain damage, actually do have brain damage.
Yeah.
So Tracy had a question, is the loss of hippocampal volume actually a physical loss of size or a loss of function?
It is a loss of volume, and what happens there, so the hippocampus is one of the only regions, actually one of only 2 regions in the brain that continues to generate new brain cells. Usually when you lose a brain cell, it's gone forever. Unlike your skin or some other types of organs that are always, you know, creating new cells, your brain doesn't, except for in the hippocampus. And of course, what does chemotherapy do? But it targets rapidly growing or proliferating cells, which are found in your hippocampus. So the animal research shows that chemotherapy just suppresses that growth, but then some of them are going to atrophy and die, and so some of those are lost. But because of the nature of the hippocampus, it can create more. And so we do see with mental exercise and with physical exercise that volume loss can be recovered.
All right. We did have a question about the axis labels on some of your graphs. I don't know, unfortunately I'm not sure exactly which graph that Gail is referring to.
Okay, I'll just quickly go through them. So this is volume in cubic centimeters on the hippocampus, and then we have left hippocampus and right hippocampus. Here is, this is what we call, this one is a little harder. This is basically you can consider it to be a level of activation in the brain. So it's just a metric of activation. It doesn't really have a standard metric like millimeters or anything that anyone would understand. And these are different brain regions. BA1046 is a part here in the prefrontal cortex. BA8 is a little bit further back, and BA6 is in here. So these are all just areas of the prefrontal cortex, and this is how much these are activated. These don't really have axes. So
no, I think you covered it. Perfect. Thank you. Shelli, we had some questions, a couple different questions actually, about the chemotherapy. So people were wondering if there were specific chemotherapy drugs looked at in this study, and also does a specific type of chemo impact the severity of the cognitive problems?
Unfortunately, we had too much variation in our study to really look at that. In this first one, we actually showed a correlation between methotrexate. Those who had methotrexate or CMF chemotherapy were a little bit at higher risk, but that's a much older chemotherapy, and so that's kind of not as relevant anymore. Most of that, the answer to that comes from animal literature, because you can't randomize, humans to different chemotherapies, but you can in animals. And what they found is that there really aren't any differences between the different chemotherapies. That even the ones that aren't supposed to cross the blood-brain barrier and get into the brain are causing the same brain injury somehow. Mm-hmm. So but there just hasn't been enough research for us to know. But that is one of the goals, is to try and figure out, are there some that are more toxic than others?
Okay. And then we did have a few questions about the medications you were talking about, and we've had some women wondering if ADD-type medications, such as Vyvanse, help with chemo brain symptoms?
Yeah, so those are the most common ones that I see people taking, are what we call stimulant medications that are often used for ADHD, like Ritalin or DMPH, Adderall. And so I'm not a physician, so I can't make recommendations about those, but those are the most common ones that I see.
Okay,
great. And I don't know about the research on them, whether they're effective or not.
Okay. So we have another couple questions about the Lumosity. People are wondering, it is available to the general public, and they're wondering about how expensive is it and how long are you supposed to do them?
Well, I think it's like $50 a year for unlimited use, mm-hmm. or something like that. I can give you my discount code and you can disseminate that, and so then it'll be 20% off that as well. So it's not super expensive. You can sign up for different plans, so you can try it, for a month, and I think that costs like $14 or $15 if I remember correctly. And then the longer you sign up, of course, the cheaper it is. And there are family plans so that you can pay for one account and your whole family can use it. How long you should do it, that I don't actually know the answer to. Certainly, the longer you do it, the better you're going to get. And there have been some studies with these cognitive training that show even when you quit doing it, even like 5 months or 6 months later, you still are showing benefit. But we don't know if that will last. You probably will have to do it regularly for an extended time. I would say at least 3 months, and then have booster sessions every few months.
Well, it's like exercising your body. You can't just do it for 3 months and then say, okay, now I've done enough.
Yeah, exactly. You have to kind of keep finding ways to, in terms of cognitive training, this is just one of the ways to do it. So I would, recommend, if you want to try cognitive training, try it for 3 months and then try doing some of those other things that I suggested. So it is a lifelong thing. You do have to continue to do mental exercise your whole life to keep your brain healthy, especially if you have risk factors like breast cancer and chemotherapy. But in terms of doing something like Lumosity, that could just be one thing that you do, a few times a year, and then you rotate other things in.
Great, and so they can just, Anne-Marie wants to know, for Lumosity, they can go online and sign up for Cancer Recovery 1 and 2, correct?
Yeah, and there are a lot of other courses on there they can try as well.
Great. And we actually had, Anne was wondering, were some of the women who participated in the study long-term survivors? Because she would have liked to have done this 9 years ago, but is still interested if it might be helpful.
All of them were long-term survivors. Like
there you go, Anne.
I think our average was at least 5 years off therapy.
Okay. Cindy is wondering if you've looked at participation in CaringBridge or other journaling types of websites.
Nope, I'm not familiar with those. I'll have to check that out.
Great. Thanks for that suggestion. And then there's some other questions about other medications that women are taking after the chemo, such as Aromacin and Arimidex. I don't know if you looked at this. Are they adding to the problem?
Yeah, I don't have any data on that. I'm not familiar.
Well, those are the hormonal drugs that you referred to early on. So that you've got both the chemotherapy and then you've got the hormonal therapy, and those are types of hormonal therapy.
Okay, so our participants only had tamoxifen, but if it's, works similarly in that it blocks estrogen, then yes, those would contribute.
The other question I was thinking of too is menopause, which often chemo will throw you into menopause, and that has its own cognitive problems.
Yep, definitely. We have we control for that because it's always different between the groups, but you definitely, if you've had early menopause or even on-time menopause, you will have some cognitive changes just from that.
Great. So just a couple more questions and then we're out of time. Ellie is wondering if she can assume that having several chemotherapy treatments over 10 or more years compounds someone's cognitive decline.
That would make sense, but again, we don't have data for it. The only study I've seen has shown high-dose chemotherapy shows slightly more problems than low-dose chemotherapy, but nobody has really looked at how long in terms of duration of chemotherapy, but we do see that in other populations like leukemia who've had longer chemotherapy protocols tend to have slightly more difficulties, but I don't know for sure in breast cancer.
Okay, and Alice was wondering if time will improve these issues, and it sounds like from what we're talking about, it's just something that you need to continue practicing.
Say the first part again, if time will?
Will time improve these issues?
There is some natural recovery, so if you don't do anything at all, your brain will repair itself to a certain extent, and that's very individual within the first 1 to 2 years. So time will improve it on its own within the first 1 to 2 years, but if you're still having difficulties after that period, then you will have to probably do something more active to improve it.
Great. Okay, and then let's see. Oh, we talked a little bit about other diseases such as Parkinson's, and Jeanette is just curious if you know if anybody has studied whether Alzheimer's patients have had cancer. Is there a relationship to the development of Alzheimer's?
There's one study that shows individuals who've had chemotherapy have a higher incidence of Alzheimer's, but then there were 2 other studies that came out showing that there was no increase. So that is still a controversial issue.
Okay. And then another question just about what the patients are doing in the study. Were any of them using stress reduction techniques such as meditation, and was there any correlation between stress reduction and improved cognitive function?
Well, there are other studies showing significant association between meditation type techniques and improved cognitive function, but we did not look at that in our study. People were excluded if they were undergoing any type of intensive psychiatric treatment.
All righty. Well, we are fresh out of time. We're out of time to answer any additional questions, but thank you everyone for joining us. If you do have additional questions, you can email us. The address was sent to you in your invitation to the webinar, and you can email us and ask your questions. We will also be posting the recorded webinar on our website, so you can follow up with that. And then, Dr. Kesler, we had people requesting the discount code, so we can get that from you and share that with our members as well.
Yep.
Excellent. Well, thank you so much for joining us today. It was really great to hear the results of the study. And thank you to everyone who participated in the study and for being dedicated members of the Army of Women.
Thank you, yes.
Great. And thank you, Dr. Love, for joining us.
Thank you very much for having me.
All right. Bye-bye.